The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flightbridge Ed in their entirety. This is the Flightbridge Ed podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hello, everyone, and welcome back to the Flightbridge Ed MD cast. I'm your host. My name is Michael Loria. I am an emergency physician, EMS, and critical care physician, and the medical director for Flightbridge Ed. Welcome back to our series on OB critical care transport. So this is part 3, and today we're going to be discussing peripartum cardiomyopathy. To go back to why essentially we're doing this mini-series is maternal mortality has become a serious issue in the past several decades. As a matter of fact, since the 1980s, the maternal death rate in the United States has been going up significantly. Today, we're up to about 32.9, or almost 33 deaths per 100,000. This is compared to a lot of other countries around the world, especially our European colleagues, where in Norway and Iceland, numbers are like 1 or 2 per 100,000. This puts us in a solid 65th place around the world. And peripartum complications and maternal mortality is a major, major issue. For transport crews, it's a particularly important issue because a lot of births and a lot of maternal care happens at centers where they don't manage a lot of critical illness in pregnancy and do a relatively low amount of deliveries. So we're talking about less than 1,000 deliveries per year. And they're relatively far away from larger tertiary or quaternary centers and will require transport. So there's a high-risk population that can become critically ill, and where they become critically ill, they may not have a lot of experience with it, and they will want to transport these people. The wonderful thing about OB critical care, and one of the things I love about it, is that in general, a lot of these patients are healthy to begin with. And with that healthy protoplasm, if we know what we're talking about, if we intervene and provide aggressive critical care interventions at the appropriate time, we can actually make a really big difference and help with this issue around maternal mortality. So before I get started, I just want to say that I have no disclosures. I have no financial conflicts of interest. If I talk about a device or I talk about a particular product in this talk, it's because I think it's a good product or there's some good science behind it, and not because I am getting paid by any of the manufacturers of said devices. And always remember, this is an educational podcast here at Flightbridge Ed, and what we're going to be discussing is some cutting-edge techniques, some of my practice, some of how we manage things at this institution or the institution I work at, and as well as some of the science and evidence base. But always, please, please, please do remember that this is no substitute for your local protocols, guidelines, regulations, or laws, and please do always abide by those. So let's start out with talking about peripartum cardiomyopathy. So it's interesting because our crews see cardiogenic shock and heart issues all the time. This is like critical care transport, bread and butter. But what if you were to see it in a young, healthy, pregnant female, or a female who had just given birth, say, a week or two ago? That's kind of a different situation that we don't run into on a regular basis. But peripartum cardiomyopathy is a big deal, and it is a major complication that can happen during or after pregnancy in the recent peripartum period. What we say is that it is essentially acute left ventricular function, so heart failure with reduced ejection fraction, specifically defined as less than about 45% in peripartum women with no previous history of heart problems and no other clear identifiable cause. So a young female who comes in a week or two after delivering with increased pedal edema and shortness of breath and a chest x-ray that looks like pulmonary edema and a point-of-care ultrasound that shows markedly reduced ejection fraction. That's what we're talking about here. It's not super common, but it does happen at a reasonable and respectable rate of about 1 in 2,200 to about 1 in 4,000 pregnancies. Risk factors in general are mothers who are over the age of 30 years, African descent, multiple fetuses, preeclampsia, eclampsia, cocaine use, and prolonged tocolytic therapy. Interestingly enough, the majority of cases, although it can happen as early as the second trimester, the vast majority of cases are within days to weeks after giving birth. So usually in the first month or two after giving birth is when we see this, or it's most common for it to manifest. It's really important to recognize it, because the mortality is significant, about 9 to 11% mortality in an area is actually, interestingly enough, with even worse access to care than a lot of places in the United States. So some places in Africa and South America, the mortalities are reported even higher at about 28%. So it is a major, major issue. With early recognition, however, the majority of women actually do quite well. And in fact, the majority of them will recover normal heart function. So their EF will be back up north of 50 to 60% and essentially symptom-free for the rest of their life, should they, if they don't get pregnant again, that is. So very interesting pathophysiology here, quite different from the rest of the adult population that develops cardiomyopathy. The exact cause and pathophysiology is actually unclear. There's some evidence to suggest that it may be a function of multiple things, or the confluence of multiple things, including some hemodynamic changes in pregnancy, other risk factors potentially, things like doing cocaine and drug use, superimposed on the hormonal changes that occur and precipitate things shortly after birth. Now, remembering that in terms of talking about the hemodynamic changes specifically, remember that during pregnancy, the blood volume can increase by as much as about 40 to 50%. Our pregnant female population actually has increased cardiac output, decreased afterload, and this can actually lead to, and has been documented to result in transient LV remodeling, hypertrophy, and even in some cases high output heart failure. But aside from that, those are the sort of baseline and would be considered normal hemodynamic changes in pregnancy. And there seem to be some other precipitating factors. Some authors and scientists have suggested that things like angiogenic imbalance play a role here. So remember that the placenta secretes all sorts of products that change the property of the female vasculature. Things like VEGF inhibitors and other hormones that come to play during gestation and are created by the placenta can actually cause oxidative stress and damage the vasculature, potentially resulting in alterations in afterload. And what we see is this might actually make sense in that preeclampsia, for example, is a predisposing factor, or at least a condition that we believe is associated with higher risk of developing peripartum cardiomyopathy. Infection is actually, interestingly enough, thought to be a potential precipitating factor. Specifically, when scientists have looked at or taken serum samples of patients who have developed peripartum cardiomyopathy, a not insignificant number of them have actually demonstrated evidence of viral myocarditis, and in the setting of having a slightly weakened immune system during pregnancy. In one study in particular, about 31% of the patients that developed peripartum cardiomyopathy had evidence of viral genome or viral genetic material in their bloodstream. So there's this thought that it may be secondary to some sort of viral myocarditis. and also this potential baseline immune dysfunction. There's some literature suggesting that these patients have higher levels of immunoglobulins, and perhaps that there's some degree of fetal cells that enter the maternal bloodstream and have this weak immunogenicity and actually lodge in cardiac tissue, precipitating inflammation and myopathy. So that could be it as well. A very interesting hypothesis, especially considering the temporality. In other words, this huge spike and why we see the majority of cases in hours to days to a few weeks, 4 to 8 weeks after giving birth, is this idea that it may be consistent with the very high spike in prolactin that females experience during this period of time. So immediately after giving birth, prolactin levels increase substantially and peak within a week or two, and will remain high for a couple months after, or several months after giving birth. And it has been suggested that actually, and specifically in animal models, that some of the cleavage products of prolactin, in other words, as prolactin is broken down, can actually cause marked oxidative stress, cell apoptosis, and significant vascular and myocardial dysfunction. So that the timing with some basic science evidence in animal population seems to point to that. But there's also some interesting animal and human studies that show by blocking prolactin, we actually reduce the severity, the length, and sometimes even prevent worsening of peripartum cardiomyopathy. So in several animal studies, they used bromocriptine, which is a suppressor of prolactin, to reverse or at least improve symptoms. And there have been several pilot studies. Granted, they're very small. We're looking at like studies of 10 patients, 48 patients in another study that were given bromocriptine, and which demonstrated significant efficacy in terms of managing their symptoms, improving their symptoms, or stopping progression of their cardiomyopathy. There were two sort of larger German studies. One was about 115 patients that showed improvement in left ventricular ejection fraction, and a more recent study of about 51 patients that were given bromocriptine, and that also demonstrated improved outcomes in those studies. So I really think we're a little ways out from putting the last few nails in the coffin on exactly what's causing it, but there are some very interesting hypotheses, in particular this one around prolactin levels and potential therapies linked to that have a weak evidence basis, but again, when weighing or thinking about the utility in terms of risk and benefit, and depending upon how bad their cardiomyopathy is, that the balance may weigh in favor of treating and providing the bromocriptine. And there's also a number of case reports and case series where patients were given bromocriptine and seemed to improve. So it is out there. It's probably not something we would be giving or hang on to in the critical care transport armamentarium, as in like carrying on the aircraft, but something to have in the back of your mind. Now, getting back to the clinical manifestations, the signs and symptoms are a lot like any other patient in heart failure: dyspnea, orthopnea, shortness of breath, specifically shortness of breath at rest, chest pain, peripheral edema, specifically in the legs, just generally feeling really tired and fatigued, which you can imagine in the setting of recently having a baby and being kept up all night feeding said baby. A lot of these symptoms can be masked, especially if they're mild. So we got to keep that in mind. On exam, also similar heart changings, heart murmurs, S3 sounds, crackles on auscultations of the lungs, diagnostics, specifically chest x-ray consistent with pulmonary vascular congestion or pulmonary edema. Labs, somewhat less helpful. Yes, you can get a BNP in a lot of places, especially emergency departments will get a BNP, but it's somewhat not specific, not sensitive, or specific. Actually, I shouldn't say that. It can be specific in the sense that the greatest benefit, perhaps, of getting the BNP is if it comes back and the BNP is super low, like 100 or something like that. You should probably be hunting down other causes of very sensitive, not very specific, in the sense that if it is very low, then it is probably not cardiomyopathy or heart-related issues, and we should probably at least extend our differential to think about other reasons why someone could be short of breath. But the BNP generally less helpful. What may be pretty helpful to us, especially in the time frame of being called and flying out to a ascending facility and having the patient right there in front of us, if labs and some of these things aren't immediately available, is point of care ultrasound. I can't emphasize this enough, and it is growing in popularity. There are a number of critical care paramedics and nurses that are getting very good at basic point of care echocardiography and basic point of care ultrasound for other examinations, and this is a fantastic example. It is very easy once you get facile with the ultrasound to actually be able to get some views and look at some fundamental hemodynamic parameters or cardiac parameters. So looking at the heart in a couple of different views and assessing if there is substantially decreased ejection fraction or at least markedly reduced surrogates, such as things like fractional area of change or fractional shortening. Something we can talk about in another podcast. Also evidence of decreased stroke volume. So you can actually look at things, something called the velocity time integral. And you can look at using Doppler, how much blood or the flow of blood out of the left ventricular outflow tract in one of these very standard views of the heart. And you can relatively quickly quantify how much blood their heart is shooting out with each cardiac cycle. And I think those things can be super helpful, more helpful, I think, than very vague lab findings or other things on a chest x-ray. Likewise, what you can do is you can do a good lung exam. So looking at the lungs and finding 3 or more B lines in multiple lung fields. When you add that together with a point of care ultrasound exam that shows decreased cardiac function or specifically decreased ejection fraction or a surrogate thereof, I think that is pretty good evidence in conjunction with the symptoms that the patient is demonstrating that they're potentially demonstrating peripartum cardiomyopathy. So that is sort of the signs and symptoms, but let's get into the nuts and bolts of sort of the management and what you might do as a critical care transport provider. Remember that peripartum cardiomyopathy may exist on an entire spectrum. These patients actually may have a mildly reduced ejection fraction with some symptoms, but otherwise be doing okay. And very often they're treated like any other patient in heart failure. With diuretics, so sometimes you'll see them on Lasix, Bumex. They might be on beta blockers. They might be getting hydralazine or nitrates to actually reduce the afterload the heart experiences. Occasionally, you may even seen someone on PO digoxin. So that's a possibility as well. And every now and then, after the appropriate provider, a cardiologist or someone has actually looked at their EF and assessed their kidney function, you may even seen them on an ACE or an ARB for afterload reduction as well. And that is specifically only after delivery. Some of those medications would be not indicated or contraindicated if the patient is still pregnant. So when the EF actually starts to get real low, one thing you also might see some of these patients on as they're starting to get sicker or developing worsening cardiac function is that they actually may be anticoagulated. And so there is a risk of LV thrombus as the EF starts to go down substantially. And you may see some of these patients on low molecular weight heparin or enoxaparin heparin or occasionally argatroban or a DOAC. This is relatively uncommon, but you can see it from time to time. So you may see a patient who have been admitted and started to be treated as a patient who who is having evidence of heart failure and peripartum cardiomyopathy. You may even see them as they were managed as outpatients, but now they presented to the ED of the sending facility, and now they're sitting there. So you may see them on this, on some of these heart failure medications, and that could be clues as to what is actually going on. Now, in the setting of severe acute decompensated LV failure and cardiogenic shock, these are the patients that we're really getting worried about. And these are the patients who we will likely be seeing in critical care transport as these patients are moved from smaller sending facilities to larger tertiary and quaternary care centers. I think that the way that I've approached this in general, again, getting back to some human factors in terms of weaving some of those human factors in resuscitation, is try to keep it relatively simple and try and keep it to a mantra of a handful of key concepts, key guiding principles, steps, or concepts that I try and keep in my mind. And when it comes to decompensated heart failure or severe acute LV or decompensated LV failure and cardiogenic shock, I actually adopted a relatively simple set of key principles to keep in mind that were originally presented by Josh Farkas on the PulmCrit website. And they are as follows. So improve and maintain oxygenation. That is number one. We can do this quickly and pretty effectively by adding on CPAP or BiPAP, and we should consider intubation if necessary. But I think by and large, CPAP or BiPAP have reduced the need for intubation in this specific, in the heart failure population overall. And that would be number one. So improve oxygenation and help them ventilate. Optimize their MAP and perfuse the ventricles. So in terms of optimizing the MAP, we can see sort of on a spectrum of hemodynamics, patients who are very hypertensive and have a pretty substantially increased afterload, and patients who are hypotensive and in shock. And so if they're hypotensive and in shock, norepinephrine is probably across the board in the setting of heart failure, the first step in terms of adding a vasoactive agent. And I think there's enough evidence at this point to substantiate this. You can also think about adding low-dose epi, but I'll talk about that a little bit more in one of the following steps. And if they're really hypertensive, you can consider nitroglycerin or hydralazine. You won't get into a lot of the judo of using nitroglycerin in this setting, but in short, you're going to be looking at higher infusion rates. You're not starting at the old anti-anginal doses that we used to use of 10, 20 mics a minute. You're looking at hundreds of micrograms a minute, or even bolusing nitroglycerin to those patients. So norepinephrine if they're hypotensive or appear to be in cardiogenic shock, and then if they're very hypertensive and appear to have a substantial afterload in the setting of congestive symptoms with their heart failure, then nitroglycerin would probably be my first go-to. Careful management of volume status. If the patient's hypotensive or even normotensive and there's evidence of volume overload and congestion, pulling them back on that Starling curve, giving them some Lasix or some Bumex under those circumstances would definitely be reasonable. It's not always the most effective tool in our transport arsenal, because even if you've given it to them right now, it's going to take hours for them to actually produce that urine and lose some of that volume. So it's not super fast acting, and it may not even be something you see the effects of over the course of a transport. With some patients, especially if they're borderline sort of on the edge of hypotension and hypoperfusion, I would absolutely discuss this option very carefully with the sending provider and or the receiving provider. Adding inotropes. In general, there hasn't been fantastic literature to suggest adding inotropes. This is largely in the in-hospital patient setting, in the ICU, specifically the cardiac ICU. However, as a sort of finger in the dike salvage maneuver, if we think that patients are not responding to initial therapies, throwing on the probe and specifically identifying that their ejection fraction is either low or worse than previously documented, adding an inotrope may be helpful, especially if they're still having congestive symptoms and not responding to things and hypoxic or require BiPAP, to augment their inotropy, help some forward flow, and enable you to safely get them to definitive care. We can do more precise diagnostic interventions to figure out what the particular best therapy and best path forward may be for them. Treat the underlying problem. So this may be the place to consider something like bromocriptine in the setting of peripartum cardiomyopathy. Again, this is really not something that I do on a regular basis. This is really outside the standard critical care transport guidelines. I have not seen this in anybody's guideline. I'm sure there are some peripartum or OB teams out there that specialize in this that do it, or even may carry bromocriptine. But I would say by and large across the industry, it's not something we do. If we're thinking about adding this on, specifically in the setting of peripartum cardiomyopathy, then I would absolutely make sure that the sending provider and or receiving provider approve of this intervention and are willing to prescribe it and give it. And finally, and I add this on, especially in the setting of critical care transport, number 6 is communicate and coordinate. So improve their oxygenation and ventilation, optimize their MAP, manage their volume status, add inotropes if you need to, treat the underlying problem, in this case, consider the bromocriptine and talk to the sending and receiving providers about that. But an extension of that is number 6, which is specifically communicate and coordinate. These patients are fairly complicated. They're OB patients that have recently given birth, but now they're also kind of like cardiology patients, and they're generally, when they're getting to this stage where they're essentially in shock and requiring BiPAP, CPAP, intubation, whatever, they are heading toward a critical care unit. So under these circumstances, even working in the ICU myself, I will absolutely coordinate with a maternal fetal medicine, talk to the receiving facility, make sure I'm not missing anything or there aren't specific details about this patient's management that I haven't received or were not in the paperwork from the sending facility. So I will absolutely coordinate, talk to people, and make sure we're all on the same page in terms of management of some of these very complicated patients. So communicate and coordinate, especially with the receiving facility. Finally, I would say in the setting of acute heart failure, especially with patients like this, and when the EF is very, very low, arrhythmias and sudden cardiac death are very real complications. So from a logistics standpoint, I'll absolutely put the pads on these patients. I've had 2 of these patients in my career, and I will absolutely put the pads on them. Let's talk about mechanical circulatory support. So if by some chance you are picking them up from a tertiary care center or quaternary care center or secondary or tertiary care center and taking them to a quaternary care center, for example, for evaluation for transplant or for evaluation of a durable VAD or some other specific intervention, they may already have a mechanical circulatory support device in place. And also, kind of like in what we see in cardiogenic shock, we have various devices. So there have been reports in the literature, case series of some of these patients that have been supported with balloon pumps. They've been supported with LVADs. They've been supported with ECMO. And we very well may see peripartum cardiomyopathy patients requiring some degree of circulatory support, mechanical circulatory support. And like with any other patient group that's experiencing cardiogenic shock, the big question is, do we need to support the left ventricle? Do we need to support the right ventricle? Or do we need to support both? LVAD, specifically Impellas or the balloon pumps, are great if you have a normally functioning right ventricle that's doing okay, and it's really the LV that's struggling. For biventricular failure, VA ECMO is probably the way to go once patients progress to SCAI stage DE cardiogenic shock. They're refractory to multiple pressors and are generally doing very, very poorly. So if you're at a center that can do this, or you're bringing the patient to a center where this is a possibility, this may also be something that's worth discussing with the receiving team. So in summary, peripartum cardiomyopathy is essentially acute LV dysfunction, defined as a reduced ejection fraction below 45% that most commonly occurs around the time of delivery or shortly thereafter, within sort of weeks to a month or two range, in a patient that's otherwise healthy, has had no real history of heart problems, and there's really no other inciting factor or issue other than having recently delivered or being pregnant. And the cause remains somewhat unclear, but it's thought to be perhaps this confluence of multiple things: different risk factors, hemodynamic changes during pregnancy, and perhaps, as one hypothesis has suggested, this idea of prolactin degradation factors from this prolactin surge that patients experience shortly after giving birth. And remember, the nice thing about this is actually the most important thing is really identifying it or thinking about it, especially if the diagnosis hasn't already been made. And the wonderful thing is that you can treat this like we are so used to treating heart failure in other patients by and large. So we optimize their oxygenation and ventilation, get them on CPAP, BiPAP, or intubate them if needed, optimize their map, and make sure there's appropriate and effective perfusion of those ventricles, that their coronary perfusion pressure is where it needs to be. If they're hypotensive, add on some norepinephrine. If they're really hypertensive, you can consider nitroglycerin or even hydralazine. Careful management of the volume status, definitely talking to people or the sending and receiving provider, but it would not be wrong to at least begin to help them diurese if they're normotensive or hypertensive, and adding inotropes if needed, specifically epinephrine if they're persistently hypotensive, or in some cases, and I would very carefully evaluate patients here because dobutamine may be a reasonable option, but it can also make things worse and actually make patients hypertensive by decreasing their afterload. So epi would generally be my go-to if they're borderline, if they have borderline blood pressure or they're hypotensive. And before reaching for the dobutamine, I would think about it very carefully, do a couple of other things. And if it is not, if there's not a provider or physician on the retrieval team or the critical care transport team, definitely something I would discuss with the sending or receiving physician before starting something like dobutamine. Treat the underlying problem. In this case, if it hasn't already been started, considering the medication bromocriptine. Again, something we don't usually carry. You'll probably have to get to the sending facility, and absolutely 100% requires a very in-depth conversation with the sending and receiving team. And finally, on that note of the sending and receiving team, make sure we communicate and coordinate appropriately. These are definitely patients that I would check in with the sending team about and make sure that everything that needs to be done for this specific patient population is being done and or considered. So thank you guys very much. That was installment number 3 of our OB Critical Care Transport series. Please feel free to leave us any comments, as with the other sections or the other episodes on OB Critical Care and Transport. I'll have a series of show notes and all of the references in there as well, so you guys can go ahead and look them up. So until next time, in our 4th installment of the OB Critical Care series, thank you guys very much for listening. Take care and fly safe.
This has been a production of the Flight Bridge Ed podcast, leading the way in pre-hospital critical care and emergency medicine education.